Well, hello again. We're back talking about heart disease in both the dog and the cat. And we're going to talk about therapeutic considerations for heart disease now. But we're going to spend a little bit more time talking about how we go about it, how we think about it, rather than simply talking about dosage of such and such a drug, milligrams per kilogram, how many times per day. And we want to do that so that we get a better idea, because one of the problems that we generally have is we think about heart disease as just a simple single thing to treat. But in fact, that's not the case at all. And the successful goal and the successful way of dealing with therapy of cardiac conditions is to understand where the dog or the cat or the person sits in relationship to how serious is the problem and what needs to be done. Remember that the term heart disease connotes that there's a problem. Something is happening in the body where there's something wrong with the way the heart is functioning or is pumping. But that doesn't mean that the animal or the person needs therapy. It simply tells you that there's a problem. If you will, somewhat like aging and degenerative joint disease, we know that there's a problem, but it doesn't necessarily demand care. It may, and as it does, that's what we're going to be looking at. Well, a number of years ago, American Heart Association ran a very interesting survey. They called 1,600 people randomly in a telephone survey to ask them their thoughts about heart disease. Interestingly, about half the respondents got the basic facts wrong. Almost all were aware of cardiac disease, but at least half didn't understand the most basic facts. Of the group, when they asked them questions, 70% said they had heard of the term heart failure. They heard of what it was. But then when further discussion occurred, 2/3 of those surveyed confused the signs of heart failure with a heart attack. So as we know, heart failure is not necessarily due to a heart attack. It can be. And we know that in dogs, for example, heart attacks are extremely unusual, extremely rare, and yet heart failure is not rare. So we need to understand a little bit more as to how we get to the conceptual treatment of failure. A number of years ago, quite a few years ago now, a group of veterinary cardiologists got together and developed a classification system which was referred to as ISAC, where they looked at the different levels of cardiac disease. In my opinion, what you see on the slide is a little bit long and a little bit confusing. And quite honestly, I suspect that there are very few, if any, people watching this video today who would tell you that they really classify the level of heart disease, but they should be. The oldest system for classifying heart disease was referred to as the Modified New York Heart Association, which was developed in the 50s and 60s, so a number of years ago now. And that system was used for classifying the severity of heart disease in people. And it was because this was felt to be inadequate that the ISAC system was developed by the veterinary cardiology group. When we started to classify our patients in a very large 1,500 patient study looking at NT-proBNP enzymes, we were interested in seeing how we could correlate those BNP levels with some level of cardiac classification. And we came up with a 4-step classification system. If you look at the 4-step, you'll see that the ISAC has some of their patients class 1 in our class 1, some, again in the middle, class 1B, are in our class 1 and 2 and 3. And then in class 3, they overlapped several classes. On the left was a much more complex 9 grading systems, which we were able to weed down to the 3 simple systems. And those systems are 0, no cardiac abnormalities. Grade 1, some cardiac dysfunction, but no abnormalities in either the size or the functioning of the heart. Class 2, some early functionings with developing clinical signs. And class 3 would be overt congestive heart failure. Very simple, very easy to do. And as you can see, this survival system, in fact, actually functioned to show us that on a Kaplan-Meier curve, we have 4 different levels, going anywhere from group 1, 0, to 1, to 2, and finally, at the bottom, grade 3. And the only real difference was the longevity. That is, how long these animals actually lived, which is, in effect, what we're really looking to do with our commentary on therapy. A different therapy or system that we can use pretty much goes along with the 0, 1, 2, and 3. And we say that in phase 0, we only need education. In phase 1, we really have no indication for clinical therapy in dogs or cats at this point. Phase 2, where they are starting to show signs of cardiac enlargement, cardiomegaly, left atrial enlargement, maybe even early fluid collection, we have different drugs that we use. And then when we get to overt heart failure, it becomes a much more inclusive all of the drugs that we need. And at this point, we also talk about anti-cytokines, we talk about nutraceuticals, and we talk about diet. So the presence of heart failure ends the asymptomatic state, which really, if we're looking, it ends states as 0 and 1. At this point, treatment here is a requisite to long-term survival. It's not to say that patients with phase 2 cardiac disease will die immediately. They won't. But long-term survival is better enhanced by starting drug therapy. The prognosis worsens substantially as the animals move from phase 2 to phase 3 therapy. And certainly this slide and the previous Kaplan-Meier curves shows us that that does happen. So we have clinical cases in large numbers, evidence-based medicine, to show how we can treat our patients more effectively. This is a human scale, which actually I quite like, and hopefully you'll be getting copies of these as handouts so that you'll be able to see how they think in terms of, on the right-hand side at the bottom of your triangle, quality of life symptoms. On the left-hand side, hemodynamic or physical function. So we want to fix both if we can. In the middle of our pyramid are those patients that need to be hospitalized. We need to treat heart failure with reduced ejection fraction. And now we're also learning that we need to treat heart failure with normal or reduced ejection fraction. And the top of the pyramid is that percentage of patients that are on their way into the dying process. This is obviously all part and encompasses all parts of our treatment needs and desires. So there are certain things that we should consider when we have a patient with some evidence of heart disease. Things that we want to ask during the physical exam to tell us that our assessment is correct. We are interested in knowing, has the animal gained or lost weight? Has the animal changed its appetite? Is fresh water available? Is polyuria and polydipsia a concern? Is the animal reporting urinary incontinence? Is the report an indication as to frequency of urination? We want to combine, as we'll see at the end, are we dealing with comorbid diseases? Coughing, respiratory control, very important. Perhaps the most common clinical signs in both the dog with coughing and the cat with respiratory excess. How is walking? How is exercise? We want to know about the costs of treatment, the frequency of follow-up, and what the client's interest here is, so that we can determine how far we should be talking to the client about therapy, and also their ability to give therapy, and to give therapy more than once a day. Supplements always come up with probably 80 to 90% of our clients. We'll talk about that at the end. So how do we manage heart disease and heart failure? First, we identify what disease is present, and we be certain. Second, we look at the stage of the clinical state or clinical condition, as we talked about at the beginning. And using evidence-based medicine in your SOAP process, identify what we want to do. What if the client says, can't afford to do any of that, doc, or I don't care to do any of that? Then it's necessary to make an informed, rational decision as to therapeutic options. And some of those decisions, quite honestly, have to be, we're not going to go full-blown, potentially making the dog sick, losing its appetite, not eating. We may be dealing with the client's desire to simply modify or temporarily provide some symptomatic relief. We can never forget the vicious cycle of heart failure, because when heart failure occurs, cardiac output decreases. We get compensatory mechanisms in the body, sympathetic activity, that is, activity of the autonomic nervous system. We get the renin, angiotensin, aldosterone activity, the production of renin, and then ultimately angiotensin, leading to the production of more antidiuretic hormone, excessive vasoconstriction, sodium and water retention, further preload and afterload increases, and more heart failure. And on it goes as it progresses. The first evidence-based study in clinical medicine and cardiology was in the early 1990s, when we studied and showed the Kaplan-Meier curve on your right, showing that dogs that received either enalapril or benazepril lived somewhat longer and somewhat better quality of life than those dogs without. And that usually was somewhere in the range of 3 to 6 months for dogs with mostly mitral valvular heart disease, but not until the dogs went into failure. When these diseases were looked at more thoroughly by both the Swedish group and the group from North Carolina. They showed that early use of enalapril did not make any difference in terms of how long these animals actually lived. So we would say that ACE inhibitors are valid, but probably only once significant clinical signs start. Diuretics in heart failure remain the only class that adequately control fluid retention. They produce rapid and symptomatic benefits, and they are specifically labeled for the edema of heart failure in people and in dogs and in cats. Furosemide is generally the optimally chosen diuretic. We won't go into the details as to how these diuretics work because of time, but we will say that the usual oral dose of furosemide is going to be somewhere between 1 milligram to 8 milligrams per kilogram, usually, however, in the range of 1 to 2 milligrams per kilogram, and that's given based upon the owner's determination as to need. It can be once a day or up to 4 times a day. If one wishes to use it by CRI, that is by continuous infusion, the dose would be at 0.66 milligrams per kilogram loading, and then once established, the same dosage, milligram per kilogram per hour. Cats are more sensitive to furosemide than our dogs, and we normally administer furosemide in the cat at about half the canine dose. Torsemide is another very potent diuretic. It also is a loop diuretic. It's a little bit less commonly used than is furosemide in veterinary medicine. In our clinic, we generally consider it to be the next diuretic that we choose, or the diuretic that we choose when furosemide is no longer as functional as we would like. Torsemide is nice in that it has a longer half-life and a duration of availability and action of 12 hours, and it can be given often on a once or twice a day basis. Torsemide has vasodilating properties, good to compare to the vasoconstrictive process that's going on, and it helps in reducing cardiac remodeling. This, we believe, is due to the anti-aldosterone effect. And so, while we're not going to talk about it more, we should talk about the aldosterone inhibiting agents like spironolactone that are available for you to use. And very often, in the latter stages of heart disease, we'll be using torsemide and spironolactone together. Torsemide dose usually in the range of about 0.2 milligrams per kg. 0.2, so about 10% of the furosemide dose. Be very careful. This drug, as will furosemide, significantly alter electrolyte levels. So sodium, potassium, and chloride monitoring are essential. A drug that was released a number of years ago now is vetmedin, or pimobendan. Pimobendan has a dual effect of both reducing preload and increasing cardiac output. So it has what we refer to as an inodilating effect. We normally use pimobendan in the early stages of heart failure, but not prior to that. Not when we just have some mild atrial enlargement. Pimobendan is usually used in dogs at the dosage of somewhere between 3/10 and 6/10 of a milligram per kilogram. This is given in a divided twice a day dosage range. Pimobendan, as we said, works as a systolic inodilator. So relaxes the heart, relaxes the vessels, and allows the heart to pump at the same time more effectively. We know that sarcopenia and cardiac cachexia occur with heart failure patients. We're all familiar with big, strong, robust people and dogs and cats that suddenly begin to lose weight, begin to accumulate fluid, develop coughing, respiratory distress, exercise inability. And it occurs because they have elevated levels of tumor necrosis factor and the leukotrienes. There are many of them, probably many, many more than we're describing here. And these products result in the loss of appetite, decreased regulation of energy, decreased weight, decreased lean body mass, decreased cardiac contractility, hypertrophy and scarring of the heart muscle, making it more difficult not only to contract, but more difficult to distend. This is something at the present time that we have no specific drugs for. With respect to cardiac diets, my thoughts on diet at this point is dogs with no heart disease, that is, in class 0 and class 1, do not require special heart diets. They do not require low sodium diets. Dogs with history of congenital heart disease or heart disease in the family are not benefited from the same. Dogs with mitral valve disease needs to be evaluated for cardiac enlargement, appearance of the lung, and decisions as to whether fluid collection is occurring. And it's only in these animals that heart disease needs to be treated with special diets. And in concluding this slide, we would say that we need to be especially careful that those diets are not ultra-low salt diets. The reason being that we're removing so much salt from the body with our medication and with our diuretics that we can easily result in electrolyte depletion. So be very careful. Finally, in a very important one-slide comment, there is no strong evidence that cardiac supplements offer any cardiovascular protection. Study after study after study has shown that. Where cardiac supplements might be helpful, the echinocoids, the fish oils, may be helpful in certain types of cardiomyopathy. And we know that taurine is helpful in taurine deficient cats with cardiomyopathy. And we have some reason to believe that boxers and other dogs with dilated cardiomyopathy may benefit modestly. Beyond that, there are no evidence-based studies to demonstrate that supplements do help. So let's wind up here and think beyond heart failure. Always think about other diseases that may be causing the clinical problems or may be causing a combination of comorbid problems. Masses in the belly, in the chest, collapsing trachea, bronchomalacia, cardiorenal syndrome, chronic heart failure, sarcopenia, and cachexia due to other non-cardiac diseases, irregularities of the cardiac rate. And again, comorbid conditions all need to be considered by you before just jumping to a very quick and rapid decision. With that, thank you so much for listening. I think pretty much we've come to a nice conclusion about how we approach the treatment of cardiac disease. Thanks again.